Okay, could you start out by introducing yourself, give us a little bit of information about your background, and then tell us about your research interests?
Okay, sure. So my name is Ellyn Riley. Let's see, I'm an associate professor at Syracuse University in the Department of Communication Sciences and Disorders. Let's see, I'm clinically trained as a speech language pathologist. I'll probably refer to that as SLP throughout our talk here. And I've got a PhD in communication sciences and disorders from Northwestern. I've been here at SU for about 6 years now. I'm the director of the SU Aphasia Lab. So we study aphasia, which is a language disorder that occurs pretty commonly after stroke or other kind of brain injury. A little bit more specifically about research interests, my lab studies, and we study the different kinds of variables that can affect treatment outcomes for people with aphasia. And also we work with different types of existing speech and language therapy and try to modify those methods and see if there's other ways that we can enhance effects of those existing treatments.
That's fantastic and a very important problem space. Stroke is certainly one of the most debilitating diseases of our time. And I think some of what I've seen suggests that we're moving more and more towards a personalized medicine effect where you can't exactly use the same therapies for each case because the brain is organized somewhat differently for each person and reorganizes somewhat differently. Did you want to comment on that?
Yeah, absolutely. I think that is definitely where the field is moving. And I have, colleagues who are even looking into that even more specifically of looking at how can we look at specific patterns in the brain. So doing different kinds of brain scans like EEG or fMRI and looking at how those kinds of patterns might even predict different patterns of recovery and how we can tailor treatment to individuals. So it's definitely moving in that direction.
That's great. Can you tell us give us a little bit more detail about your work? Do you use a standardized treatment protocol platform, or are you actually trying to innovate in that domain as well?
So we have a lot of different kinds of treatments that we use in the lab. So the kinds of studies that we've been doing using EEG are a little bit sort of like modifications of existing treatments for reading and sentence production. So we've kind of modified those a little bit more for like experimental purposes in the earlier stages. And then later on, being able to introduce those same kinds of things with the technology components more in a clinical setting. So that's kind of where that is going. So we don't have one set treatment protocol that we use for an upcoming study. So I just got funding from the NIH to do a large clinical trial. And for that study, we're going to be using a different kind of treatment that focuses on sentence production in the context of attention training.
Ooh, congratulations. That's fantastic.
Yeah, thanks. We're very excited about that project.
You just heard about it?
Yeah, we just got funded this last month. So
wow, that's great.
So all the startup stuff going on right now, trying to get everything planned and ready to start recruiting and enrolling people. So lots to do, but it's very exciting.
So tell us a little bit about that. What type of attention protocols are you using?
So we're actually testing a type of brain stimulation, transcranial direct current stimulation, tDCS. So we're looking at the potential effects of tDCS on enhancing effects of this language attention treatment. So we're looking at some different ways in terms of the behavioral treatment. There is a program that is out there already that's been published and has some evidence behind it. And so we're going to be taking pieces of that and then using tDCS and having different clinical groups. So we'll have an active group and a sham group and looking at potential enhancement effects from the tDCS. So it's pretty exciting. And
yeah, that is really exciting. Yeah, we worked a little bit with tDCS. I'm looking at effects both on memory and on attention, but more to enhance human performance in intact individuals. And there's some promising data. Even with
absolutely.
Yeah. So
Yeah, we did a few pilot studies in our lab just prior to this study, looking at artificial grammar learning and using it in trying to enhance attention to enhance artificial grammar learning. And we have a study we published last year in brain stimulation that was using undergraduate students and trying to train them in an artificial grammar and stimulating dorsolateral prefrontal cortex and with the tDCS. And so we found some interesting effects there, showing some enhancement in the active group. And then we had another pilot study that's currently in manuscript preparation, using people with aphasia, also doing that same kind of artificial grammar training. And we did show improvements in a different kinds of like non-linguistic attention skills, as well as some of the language things that we
that's
tested.
fantastic.
Yeah,
I think
so
that, a lot of, we did some work with the Air Force, and there we were looking specifically at sleep deprived individuals and trying to use the tDCS to mitigate some of the effects of sleep deprivation. And it did have an attention enhancing effect. And I can see the parallel with any brain damaged population. You're going to have, they're more fatigable, they don't sleep as well. So even if it's just a global effect of it, of enhancing alertness and not even a specific, attention channel, you still could improve performance substantially. I'm assuming you're also looking at neuroplasticity. Do you look for changes using other, obviously we do EEG, but there are many approaches that you can use to assess neuroplasticity. Is that something that you're actively involved in as well?
So we, in this particular study, we're not looking at that. So we're trying to, actually one of the focuses of this particular tDCS study is to try to sort of streamline the use of tDCS for clinical purposes. So the way that tDCS is most commonly applied now is using other kinds of technologies like fMRI to be able to do a scan with a patient prior to tDCS, so that you can precisely target paralesional areas that might be important to enhance with tDCS. But we're actually using a different kind of an approach, because if we think sort of down the line of thinking about how we might implement this realistically in a clinical setting, the additional cost of things like fMRI are just simply not feasible for most clinical settings.
Absolutely.
So we're trying, So we're trying something different. We're trying actually to stimulate the attention and language network through a different route. So we are stimulating dorsolateral prefrontal cortex as a way to enhance attention, hopefully, and also to hopefully activate parts of the language network during these specific language attention tasks that we're going to be doing. So and what's interesting about dorsolateral prefrontal cortex is it's in people with aphasia, it's rarely affected. So the lesions in people with aphasia are usually more around like Broca's area or more posterior. And so dorsolateral prefrontal cortex is usually intact brain tissue. And so we're attempting to access attention and language networks through a different route. So rather than trying to target those more active paralesional areas that you would need fMRI for, we can just simply use a structural scan, which almost everyone who has a stroke and comes into the hospital is going to get structural scans. So that doesn't add any cost. So we're taking into account this sort of the cost effectiveness of tDCS and trying to figure out, are there other ways that we can implement this effectively, and also pay attention to what's going to be feasible in the clinic.
Absolutely. That's really important. How, in general, it sounds like you're very active in your research lab. Has COVID had a significant impact on your research activities?
Up until this point, it has. We're going to have to see how that plays out in the next few months, of course. But since March, we've had, until just very recently, we had a complete pause on all human subjects research at our university, as I think most universities
Yes.
have had. And so we've only recently started getting back into trying to figure out what the protocols are going to be. So it's a slow process of getting one protocol sort of approved at a time, and trying to and see how it works. And I think we're all sort of waiting to see how all this works. But we're also looking at other kinds of things. I think some kind of positive things have come out of this experience, in that, at least in our field, we can think more about how we can approach these kinds of therapies from a telemedicine standpoint.
Yes,
And
absolutely.
yeah, so I know that, so we have an in-house speech and hearing clinic in our department. And I know we've been doing a lot of teletherapy with clients in our clinic. And so we're also looking at ways that we could potentially do this with research studies as well. So not everything, of course, lends itself to telehealth.
Yes, true.
But we have to, figure out, are there things that we can, are there ways that we can maybe decrease the number of times they have to come into the lab, or, and then what could be done from the patient's home. So
Right.
trying to figure out modifying
Yeah,
protocols.
we're all exploring any creative ways that we can work with
Absolutely.
people where they don't have to come into the laboratory.
But I think that's also where, like, mobile technologies, like all the B-Alert stuff, is
Yes,
really great, because, as a clinician, you can just take that with you and go, potentially go to a lot of different sites. It doesn't have to be,
yeah.
one
And we are
thing.
doing more and more work where we're going into the patient's home with the device or devices.
Right.
And we even have a simple 4-channel device that you can put on yourself. So, if
Oh,
you're
great.
willing or able to work with just 4 channels of EEG, there's quite a bit you can still do with it once you've defined, the biomarkers or the parameters that you're looking for.
I'd love to get more info on that.
I wanted to go back to something. So what are your thoughts? So there has been some linkage between COVID and strokes. That is probably going to make your life more difficult and easier, in that you may have a larger patient population to deal with.
Yeah, it's something that we as clinicians have been noticing. I personally don't practice clinically right now, so I haven't seen it firsthand, but I, have heard from colleagues who are working clinically that this is definitely an issue that is starting to come up, and not just with having or putting at a higher risk for COVID, and also for potentially being one of the causes of what's going on with these individuals. A lot of these people are experiencing issues long after recovery, so remaining cognitive issues that
Yes.
are not recovering quickly. So I think even beyond stroke, even individuals who have recovered from COVID are now going to be requiring other kinds of services that
Right.
hopefully speech pathologists are going to be able to supply
Yeah.
them with.
Yeah, rehabilitation, cognitive rehabilitation is going to be really important.
Absolutely.
Anytime you're deprived of oxygen, your brain is deprived of oxygen, as with, impaired respiration, you have the potential for damage and long-lasting effects. So we're in for a long haul.
I have been encouraged, though, to see a lot of new funding opportunities for research that's specific to neurological disorder and COVID. So
yes, absolutely. That's the good news.
Yeah.
Are students back on campus at all, or is your lab open, or?
Yeah, great question. It's partially open. So we have, of course, rules about how many people can be in the lab. It makes it challenging. So we do most of, right now at least, we've done most of all of our lab meetings are remote and things like that. So if we don't have to be in person, we're not. But as we start getting this next study ready, there will be times when we'll have to be in the lab, but of course, paying attention to social distancing and all of the requirements for PPE and all of that. So I think it's sort of an adjustment of figuring out, how to make all of that work with previous protocols, right? But students are back on campus, sort of. So in the fall, at least for SU, we had sort of a hybrid model going on. So my particular classes were too big to do in a hybrid format, because you have to have pretty large classrooms to have the social distancing, appropriate social distancing. So my classes have all been online, but I know that many of my colleagues have been teaching in a hybrid format where they're doing online and in person simultaneously, and then they switch off during the week to a different group of students. And so, that presents,
hopefully those models will improve over time too. The education system just has to go through a radical overhaul, as do we all.
Yeah.
One question I like to ask everyone is if you were suddenly the beneficiary of large amount of research funds, what are kind of the dream research projects that you would love to do?
Wow, that's a great question. Well, I would say, yes, dream scenario. I would say I actually feel like I'm sort of on that path right now with this new.
Wow, that's great.
So, I can't do everything right with one grant, but I think that this is the start of a lot of the things that I want to do. So I can foresee, this is a phase 1 clinical trial where we're testing, the efficacy of this particular treatment combination, but I can definitely foresee down the road looking at other kinds of things to look at the mechanism of change. So using physiological measures like EEG to look at those changes and figure out what exactly is going on with the neuroplasticity. So I think that's kind of the next direction. If I was doing a really large, like R01, hopefully that will be the next step.
That's fantastic. Well, congratulations again.
Thank you.
To be awarded or rewarded for your research passion, that's the best combination. What about translation? So do you work directly with a medical school, or do you have a training program at your university for rehabilitation? In other words, do you see a path for transitioning these technologies like tDCS rapidly into the clinic?
I do. I think that so SU does not have its own medical school, but we do have this Upstate Medical University, which is right next to us.
Okay.
And I'm also affiliated with Upstate.
Yeah.
So I have an adjunct appointment with Upstate, and so I collaborate with a lot of the people over there, and that's where a lot of the recruitment happens for my studies is through Upstate. And also we have an affiliate with Krauss Neuroscience Institute, and so we have definitely clinical affiliations in the community, and so I can definitely foresee some of these things making their way over into the clinical setting. But even more directly than that, one really great opportunity in the speech and language world is that we have this department, speech and hearing clinic. So things that we are testing in the research lab, when they're ready for translation into clinic, that's a really great jumping off point, because we do have people coming into the clinic who could benefit from those kinds of things.
That's really important.
Absolutely.
Is there anything that we could do? I know we've worked together on a number of different studies, several with aphasia patients. Is there anything that we could do to provide better service or equipment for your research, or know-how, anything that we could do to facilitate?
Yeah, I think that one thing that I've really appreciated over the years is that support, that level of support that you all have provided. Anytime we've had questions about anything, or experiencing any kind of issues, technical issues, it's very easy to contact you and your team, and we get a response back, and we get a very thorough response and a lot of help with that. So that has been a big difference between ABM, I think, and some other companies that I've dealt with, is that there is that support behind all of your products, and so it makes it a lot easier to use. Right now, so now that we're sort of transitioning to this other project, I have sort of less EEG going on in the lab, and also with COVID, it makes it a little bit harder.
Yeah.
But I do have several students who are really interested. One student who's doing an offshoot study of one of our recent publications, who's using the X10 system, and she's going to be comparing a linguistic task and a non-linguistic task in individuals with aphasia to see if we get similar kinds of findings to our original study with people with aphasia. So is this something that's just related to the language disorder? Or is this something that's more global to attention? So that's
Right.
kind of where she's going with it. And she's in the
That's
process of collecting data, you know, as we can. She still has a few more subjects to run.
fantastic. That's great.
Yeah. So I would say just keep doing what you've been doing and just keep providing that same level of support. It's been very, very good for us.
Well, thank you. That's something that we try to put an emphasis on. And I know that you've worked with various of our engineers over the years. They're hard to hold on to these days. There's a big demand for bioengineering.
They've all been excellent. Yes.
Yeah, well, that's good. Anything else that you would love to share? I mean, we're trying to, disseminate information, to the greater audience. Maybe share a little bit more about, if you're willing, about the type of tDCS equipment you're using,
Sure.
what types of probes. I know we've worked with several different systems, but can you describe a little bit more about what you've selected?
Yes, so we are going to be using the Soterix mini CT devices.
Right. Yes.
Yeah. So what's nice about, well, there's a lot of nice things about them, but they're portable and they you program them for all the different conditions using what current you want and the duration, all those kinds of variables, and then the clinician and the patient are both blinded to the condition. So you have a code. So the experimenter, or so in our case, we haven't quite figured out all the details, but we're setting up a system so that the clinician is blinded and the patient is blinded. So it'll be a double blinded study. So they will just have a code that they enter into the device, and the device will provide the parameters of the stimulation, and they won't know whether they're getting the real stimulation or the sham stimulation.
Great.
Yeah.
Yeah, I think that there's still a lot that needs to be determined about the type of stimulation, the location. Are you working on those parameters, or are you using a fixed protocol that has already had some track record of success?
Yeah, so we're using a fixed protocol because this is a clinical trial. So we're really focused on the effects on the tDCS on this type of training and the outcomes of the training. But I absolutely agree that there's a lot we still don't know about all those things, like all those different kinds of parameters. I work pretty closely with the NM4R Center, which is the Neuromodulation for Rehabilitation.
Yes.
And I know that there's lots of researchers who are working on those questions and constantly working on those questions, and there's always new information coming out. But we decided to go ahead with a fixed protocol for this, mainly because we're focusing on the more clinical question. Sure. And also we had demonstrated success with our 2 pilot studies using these particular parameters.
That's great. And how frequently do you apply the stimulation? Is it over a weekly, or over what time period?
So we're going to be doing 10 treatment sessions, and within each treatment session, they received stimulation for the first 20 minutes of the session, but they receive an hour of the speech and language attention therapy. And so there will be so there's some limitations to like the practical reasons of scheduling people, right? So we want to be as consistent as possible across participants, but we also know it's really hard to do that in real life with real patients. So 2 to 3 sessions a week for 10 sessions. Okay. And that's what we'll be doing. And we do have some pre-testing, some language and cognitive pre-testing that we'll do, as well as post-testing. And then another sort of unique feature to this particular clinical study is we will be doing some follow-up at 1 month post-treatment. So that's one of the limitations of some of the current literature, is there's not really that additional time point of what happens after they're done. Right. So that will be another important variable we can look at.
Yeah. How soon after stroke, like at what period of time are these patients? Is that consistent? How long do you wait post-stroke, or is it the standard window when you would start speech therapy or communication therapy?
That's a really great question. So we, for our study, we're going to focus on individuals who are in the chronic stage of recovery. So what we're defining that as anything post 6 months.
Mhm.
In the first 6 months to a year, really is there's a lot of spontaneous recovery that occurs. And so for our study, we're trying to avoid too much overlap with the spontaneous recovery period, so
Yeah.
that we can make sure, and realistically too, most patients who come into our study are at least 1 year post-stroke. We don't get a lot of people who are new strokes, but we get a lot of people who, honestly, a lot of people who've gone through rehabilitation and are still wanting and needing more
Right.
therapy, and
Right.
come to us for that.
That's great. So then they're very motivated at that point too, because they've probably gone through all the standard medical rehab and still are motivated to, have additional improvement.
Absolutely. And that's actually one of the joys of working with this population is they are so motivated. And something I talk to my students about a lot is just thinking about, people who are trying to recover, and just how motivated and how inspiring it can be to work with those people.
Absolutely. Yes. And even small incremental improvements can, induce a lot of excitement, enthusiasm. So you have the energy to get on to the next level.
Yeah,
That's very rewarding.
it is.
Well, this has been a great conversation. Is there anything else that you would like to discuss or talk about?
I don't think so. I mean, I think this has been great. I appreciate you inviting me to chat with you, and
Yes, and it was good timing to hear about your new project. That's
yes,
fantastic. I think there's
yes, so
so much that can be done in the stroke rehabilitation area, and I'm glad to see you focusing on that.
stay
And
tuned. Maybe we can do it again, and when we have some results in a year or
that
two.
would be fantastic. Yes, that's always fun to discuss, or
Yeah.
maybe a video of a patient, or
Oh yeah, that'd be great.
And please feel free. I know whenever you publish, we try to socialize that on our website and, communicate with other investigators that might be working in the same field. So please continue to share any publications or any news with us, and we'll disseminate as much as we can.
Great, thank you.
And let your student know if they need any help with the B Alert system. We're happy to help.
Okay, I will.
All right. Thank you.
Thank
Best
you.
of luck with everything.
Thank you.
Okay. Bye-bye.
Bye.